Okay, we're going to talk first off on ventilation perfusion ratios, and then we'll talk about control of ventilation. So Module I and Module J. First of all, just as a review. I want a highlighter, I want a pen. Just as a review, normal alveolar ventilation is somewhere around 4 liters per minute. Normal cardiac output is somewhere about 5 liters per minute. Again, there's a little variance in there. And if I look at the ratio between those two, it comes out to be 0.8. A lot of things in physiology is 0.8. I have no idea why, but it's just kind of a cool number. When in doubt, guess 0.8. I'm lying there. We know that there's some variance throughout the lung, and ventilation and perfusion both have their greatest values in a gravity-dependent position. So you sitting upright would have greater ventilation at your bases than you would at your apices. Perfusion greater perfusion at your bases than you would at your apices. Overall, it ends up being around 0.8 between the two. We know that there's a range of VQ relationships that exist, ranging from a situation where you have 0 ventilation to where you have 0 perfusion. We're going to call that situation where you have absolutely no ventilation an absolute shunt or a true shunt. That would be an example of your anatomic shunts. Thebesian veins, pleural veins, bronchial veins. We're going to call that situation where you have no perfusion, which really is a, when you ever have a 0 in the denominator, you have an undefined number. But for our purposes, we're going to call this infinity. The symbol looks like an 8 lying on its side is a symbol for infinity. Right there. For those of you old enough to remember Ben Casey, was one of the symbols they drew at the beginning of the show. Most of you aren't even old enough to remember Mucus Welby, so I don't know why I'm bothering. But that's beside Mucus Welby. So between those two conditions where you have a 0 and an infinity, there's a whole wide range of ventilation perfusion relationships that can exist, with the ideal being a 1-to-1 ratio. Unfortunately, that doesn't happen. There's always some amount of relative shunt and some amount of relative dead space that contributes to the driving that perfect relationship of a 1-to-1 down to something less than that. We good so far? Alrighty. So my true absolute shunt has no ventilation. My true absolute dead space has no perfusion. And we're looking at something about 0.8, something a little bit less than the ideal being present. These next few slides, I won't necessarily ask questions directly related to them because they're a little confusing, but I just want to give some justification as far as why things happen the way they do. If I take a look at the alveolar oxygen levels that we end up having, so how much oxygen is in that alveolus? Well, that's going to be determined by two things. How much oxygen is brought in and how much oxygen is extracted, pulled away. How much is inside that bin is depending on how much you're pouring in and how fast it's draining out. The analogy that a lot of people will use is a bathtub where the faucet's turned on and the drain is open. What determines how much water is in that bathtub is dependent upon how wide that spigot is, how much you're filling the tub, and how much you're draining out. Does that make sense? Okay, maybe I'll draw it, because you know I love to draw so much. Here's my tub. I have a spigot draining it in. I have a drain draining it out. and I have some amount of water in there. How much water you have is dependent upon, if I increase this amount putting in, it's going to increase the amount of water in the tub. If I keep that the same, but I increase the amount of drainage, I'm going to have less water in the tub. So the control of the volume is dependent upon how much you're putting in and how much you're taking out. Okay. So let's see, the amount of oxygen entering the alveoli and by the amount of oxygen being removed by capillary blood flow. That's what I just said in English. Well, yeah. The carbon dioxide is exactly the same thing. How much carbon dioxide I have in my alveolus is determined by the amount of carbon dioxide that moves from the bloodstream into the alveolus. How much am I filling that tub? And by the alveolar ventilation, as far as how much I'm removing from that tub. So there's a relationship where ventilation and perfusion can dictate how much oxygen and carbon dioxide there is. And that's a real profound concept, and if it doesn't quite click yet, it's okay, it will over time. That's what I'm saying. I'm not going to necessarily say, if I have a situation where alveolar ventilation increases, you got better things to worry about. So, let's talk about the alveolar content inside that alveolus. So here's my tub again. I have some amount of oxygen going in. I have some amount of capillary blood flow pulling that drainage off. So this is capillary blood flow. And this is alveolar ventilation. As ventilation increases, as I put more in there, it's going to rise up. Increase this opening the spigot so it's pouring more water into the tub means I have more water in the tub. Wow, Rick, that's profound. Put more oxygen into the alveolus by increasing alveolar ventilation. I'm going to have a higher P capital AO2, and ultimately the arterial value is going to rise also. If I have a situation where ventilation decreases, less oxygen is able to enter into the alveolus. Less water is entering the tub water level is going to be lower because there's always some draining off that is there. So there's a direct relationship between ventilation and alveolar PO2. Increase alveolar ventilation, increase alveolar O2. What about perfusion? What about that drainage that is present? What about if I keep the amount you're putting in constant? That's not going to change, but I'm now making the drain bigger. Well, as I have water in here and a fixed amount putting in, the more that I pull off, the more I make this drain bigger, the more is going to be pulled off. The more is going to be drained, the lower the water level. So as perfusion increases, cardiac output goes up, more is being removed, so that value is going to fall. So there's an indirect relationship between blood flow and the alveolar value. And then lastly, as perfusion goes down, there's less being sucked off. There's more going to be in the tub. What's the bottom line? Both ventilation and perfusion, the ratio between them can affect the amount of oxygen that you have in the alveolus able to be diffused across. That's the important concept to bear in mind. And we're going to find that it's exactly the same thing happening on the carbon dioxide side of the equation. And on this one, there is something that I'm going to ask you to know a little bit more about because it's going to affect us. So really the filling of carbon dioxide is dependent upon the perfusion, bringing CO2 back to be ventilated off. The drainage is my alveolar ventilation. It's reversed because I'm talking about CO2 now coming back from the tissues, moving into the alveolus, and alveolar ventilation pulling the CO2 off. Is everybody in agreement with me there? Or follow the path that I'm leading here? So let's take a look at the two situations as far as what's going to happen with alveolar CO2 as we deal with ventilation. Well, we said long time ago that alveolar ventilation has an inverse relationship with arterial and alveolar CO2. And we kind of use those two interchangeably because by the time the blood gets through that transit point, the equilibration has happened, so our alveolar and arterial should be the same. But as ventilation goes up, what should happen to alveolar? Well, it's going to fall. There's an inverse relationship there. And the opposite is true also as far as the CO2. In the first case here, I'm draining off more, so there's less water in the tub. You think of this as PaCO2, how much water is inside the tub. As I don't drain so much, that value is going to rise. Inverse relationship. The important one to bear in mind, and this is one that I do want you to grasp, is that CO2 is not only dependent upon ventilation, it's also dependent upon how much blood is coming back to be able to remove CO2. So perfusion plays a huge role in how much CO2 is being made available to be ventilated off. Let me say that again. The amount of carbon dioxide that's inside the alveolus ready to be eliminated by ventilation is very much dependent upon the cardiac output. If you have a situation, we'll take the second example here, as the perfusion goes down, so cardiac output goes down, less carbon dioxide is able to be eliminated, so you end up having that value falling also. So CO2 is directly tied to perfusion. Where it's inversely tied to ventilation, it's directly tied to perfusion. So let's play a little game. Let's say that you're the respiratory therapist responding to a cardiac arrest on a patient. We're doing CPR on this patient. What's the purpose of CPR? External chest compressions. Why are we doing them? You basically are creating an artificial cardiac output. How it happens, well, we don't entirely know, but we know that there is blood flow that is generated by external chest compressions. Fair? So that cue that I'm talking about here is going to be reflected by the amount of carbon dioxide that's inside the person's lungs. Well, am I ventilating as part of that CPR component? That's the P part, right? We're the P in CPR, as they say. So if I monitor the amount of CO2 that's being exhaled, if I monitor the amount of carbon dioxide that's in the exhaled air the patient is exhaling, I can use that as a surrogate for cardiac output, for effective chest compressions. And Jeannie or Ray haven't talked about this yet, but there is a value that is called the Untitled CO2 value. They haven't talked about that yet, right?
Yeah, I think we saw it in one of the readings.
You saw it in one of the readings? What the hell are readings? Egan? What the hell is Egan?
What's in it? Something?
They call it PETCO. It drives me crazy. It's the partial pressure of end-tidal CO2. So at the end of the breath, at the end of the tidal part of it, what's the CO2 value? And we actually use that now. New ACLS guidelines, Advanced Cardiac Life Support Guidelines, uses end-tidal CO2 to determine if you're doing effective CPR. Okay. I got a list on the guy's chest. He's pounding away on his chest. She's getting tired. What's going to end up happening to her ability to generate effective cardiac compressions? It's going to go down, right? So what's going to happen to the amount of CO2 coming back to be eliminated off? It's going to go down. Well, if I don't have CO2 there to be eliminated off, the amount I'm going to read coming out as exhaled CO2 is going to go down also. And we actually use that value as an index to say, get us somebody else on the chest. She's a wimpy thing. Right? I don't care. Yeah, Elizabeth.
So if the perfusion's decreasing and you're letting out less carbon dioxide, wouldn't,
You're letting off because it's not coming back from the tissues. Doesn't mean your body isn't still metabolizing it, but it's just sitting somewhere in your foot waiting to be picked up because there's no perfusion. Does that make sense? If not, it's okay. But when they talk about end-tidal CO2 in your other class, this is why it's important. Because it's allowing us to use it as a gauge of perfusion. Conversely, what happens once I have a restoration of a pulse? All my magical epinephrine and my defibrillation and my other medications, all of a sudden, the person now regains a pulse, regains a blood pressure, regains a cardiac output. If I'm still monitoring that CO2, what should happen to that value? It's going to spike up. In the fancy terms, they actually call that the return of spontaneous circulation, or ROSC. Ooh, ah, ooh. But there is a way to tell, hey, wait a minute, this guy's got a pulse back. Even though we're not feeling for it because we're doing compressions, we can say, whoa, pause for a second. Let's see if I can feel a pulse and a pressure. Because as perfusion increases, that value is going to increase also. Because now all that tissue-bound CO2 that was stuck in his great toe now is being brought back to the lungs to be ventilated off, and you'll see this massive rise. It's actually quite interesting to see this happening while you're doing CPR. What's the bottom line? The amount of carbon dioxide that is able to be eliminated is dependent not only on ventilation but also on perfusion. The amount of oxygen in the alveolus is dependent upon not only the amount that you're bringing in, but how much your body is extracting. That shit sounds like ventilation and perfusion are both important. Yep. That's why we really should be called cardiopulmonary therapists, not respiratory therapists, because we're dealing with both ends. Both are very important to the process. Our,
isn't there a pulmonary unit in hospitals? It's different from, I mean, you can be an RT like the,
there are other avenues you can go, but I think what you're more talking about are perfusion techs, pump techs, who do for open heart surgery, manage the heart-lung bypass machines. And that's kind of a little bit of a separate training. RTs can definitely go that route if they wanted to. Go, it's fine. They got PEs going on, so they're going to be crying and gnashing of teeth and people vomiting, so Nancy wanted to close the door. And this is kind of what we were just saying as far as the amount of oxygen that is present is determined by how much you're pulling it off and how much you're bringing in, and the same is true. Now there are a couple of different scenarios that we had. Let's talk about a situation where my VQ ratio is increased, meaning ventilation is more than perfusion. Well, we said when ventilation exceeds perfusion, more oxygen is coming into the alveoli than is being removed, so we'll have a rise in alveolar oxygen. Okay. If ventilation exceeds perfusion, more carbon dioxide is leaving the alveoli than is returning from the body. So carbon dioxide will go down. So those situations where I have a high VQ relationship, greater than 1.0, we're going to consider those to be dead space situation. And they'll end up with a higher oxygen but a lower carbon dioxide. And again, if we think back to that alveolar air equation, oh God. Right? This technically should be alveolar, but for our goofiness, we make it arterial just for some simplicity's sake. But if that value gets smaller, I'm going to be subtracting less off here. So my alveolar value will actually be bigger. If I make the carbon dioxide level lower, it's going to be a smaller number that's subtracted off that alveolar value. So dead space will end up with higher oxygen, lower carbon dioxide levels. And this is the example of a dead space. The classic dead space is going to end up being where I have a loss of perfusion. Pulmonary embolus. Here I have my venous blood coming back. PCO2 of 45, PO2 of 40, saturation of 75. That sounds right. Some of it's going to a functioning alveoli. Some of it's blocked. It can't get to that other alveoli. So what I end up having is basically my end capillary values just passing on through. This alveolus has no participation because there's no blood flow to it. So it's all dependent upon this alveolus. Some simplicity looking at a two alveolus model, but you get the gist. There's my venous values, mixes with the alveolar values to yield a capillary value. And that just continues right on through. It has no effect from the one that's not being perfused. Look at the other way around. This is where ventilation is less than perfusion. This would be a VQ relationship less than 0.8. This is what we would call a shunt unit. Well, ventilation is less than perfusion. That means that oxygen's being removed, and you'll end up having alveolar values that go down. So PaO2 will be low. Ventilation is less than perfusion. That means that CO2 is being brought back, but is not being eliminated. So CO2 levels are going to rise. So the net effect of a shunt is arterial values that are low, and to some extent CO2 values that rise. But because CO2 is 20 times more diffusible, it's not as much of an issue. Shunts cause hypoxemia, right? Shunts are refractory, meaning that relative shunt, you're not going to see the improvement in oxygen that you expect to. Man, that ventilation and perfusion really screws you up. And here's the example. I have a collapsed alveoli. What do we call that? Collapsed alveoli? Atelectasis. I have my venous blood coming back there, same as previous, but now what it's doing is it's going past, some of it's going to good alveoli, and we're exchanging gases. Some of it's just that whatever we saw previously, just passing on through, and this is what we call the venous admixture that you end up seeing with shunt units. So the arterial value has PaO2s lower than normal values. Shunt is a cause of hypoxemia in the process. Well, throughout the body, even under normal conditions, you have a little bit of both. You have some alveoli at the top that are like dead space units because they have very high amounts of oxygen levels and low CO2 levels. These are the dead space units. And at the bases we have more like shunt-like units. But bottom line is they all mix together so that when we're done, our O2 is within normal range and our CO2 is within normal range. So there's a balance that ends up being there at the very end of the process. Okay. So in the body we have a range from total shunt to total dead space. Ideal would be in a VQ of 1.0. Normal value is a little bit lower than that, somewhere between 0.8 and 1.0. Okay. We talked about this concept previously, about the CO2 production and the O2 consumption, and magically, what's the normal respiratory quotient? 0.8. Any relationship between? No, it's just kind of the way good Lord made us. We kind of have that 0.8 keeps popping up in the process. So there's a bunch of situations we can have. Let's say I'm going to change this normal value from 0.8 to 1.0, because those are really both, anything inside that range we're going to consider a normal VQ. Anytime I have something, I'm going to make this 1.0, it's the high end of the scale. Anytime I get above that point where ventilation exceeds perfusion, the numerator is bigger than the denominator, we're going to call that a dead space. And anytime perfusion exceeds ventilation, we're going to call that a shunt. What about if I got nothing going to either? I got no ventilation, no perfusion. You're dead. Now, on a given breath, you may have an alveolus that is neither ventilated nor perfused. We call that a silent unit. It contributes to nothing, so you kind of just ignore it. But it's also, in your range of possibilities, something that could exist. So dead space, we said V was bigger than Q, and it's greater than 1.0. Classic example is a pulmonary embolus. I have a blockage in the pulmonary circuitry, blood flow wise, and no blood gets to that alveolus. It's being ventilated just hunky-dory. Who cares? Doesn't contribute. It's actually wasted ventilation. You may hear that term used. It's wasted. I'm expending energy, but there's no gas exchange. Well, how can I make this value bigger? I can increase this or decrease this. So many times I have a situation where my perfusion falls, I end up having a VQ relationship that rises. Anytime I have an increase in ventilation, same process would exist. So if I overextend the alveoli, instead of my alveoli being that big, I now make it that big because I put too much volume in there. That actually will cause a creation of a dead space. I'm sure that makes absolutely no sense to you. This is the one I want you to remember more than anything. That's the classic. Again, we showed this picture prior. Shunted blood flow is where perfusion exceeds ventilation, so my VQ is going to be less than 0.8. Is that less than? Yes. I hate that. I really do. So that means that either the ventilation has gone down or the perfusion, for whatever reason, has gone up. Well, an obstructive disease, do you have a reduction in ventilation? Yeah. There's an airflow limitation. Can't get the air out. Can't get it back in again either. Restrictive lung diseases, can't get it in. They would have a reduction in ventilation also. We call that reduction hypoventilation. This also would be what would be present if that alveolus was forced to be opened and reopened with each breath, like we see with surfactant problems. These all will cause shunt. Instead of having this nice, beautiful alveolus, I have that shriveled up little goofball that's not going to contribute to anything. Okay. Shunted blood flow. There's my atelectatic alveolus. Didn't we start here? Yeah, there's a spectrum. That's the important thing to remember. What's going to happen, and we'll find this out next semester, during disease states, you go one way or the other. Your VQ relationship shifts. Wait a minute, VQ relationship, isn't VQ abnormality one of the causes of hypoxemia? Nod your head and say yes. Very good. So we're going to see different diseases, how that manifests itself. Now here's the hard part. This is where the math comes in. This might be the kind of problem that you might see on a test, I don't know, a couple of weeks from now. Given an alveolar ventilation of 6 and a cardiac output of 4, what's the VQ ratio? 1.5. How did we do that? We put 6 over 4, did the math. What type of relationship does that represent? And what could a possible cause be? Pulmonary emboli. Well, that sounds like 3 or 4 questions I could do. What a rat bastard. Well, yeah. I capitulated a little bit on that one, on the test, so. In 1060, yeah. Let me pause here for a second. Go ahead and resume. No? No. All right, the control of ventilation that we have is based upon 3 facets. One is that you got to have some kind of control circuit or controller that's initiating impulses to go to someplace else. And that we're going to call the central controller, which we'll find is primarily the pons and the medulla oblongata. They're going to generate some impulses, some output, that is going to travel down to the respiratory muscles, primarily the diaphragm, to begin contracting. Then there has to be some kind of a mechanism by which that impulse is stopped. So there's got to be some feedback mechanism that is present to say, okay, you've taken a deep enough breath. Okay, you've successfully removed CO2, blah, blah, blah. And these are some chemoreceptors and other receptors that are present in the lungs that are there to also control ventilation in the process. Okay, let's talk about the medulla oblongata. We know that it's the lower portion of the brainstem. It's the last thing that is there prior to the spinal column originating out down the foramen magnum. So it's inferior to the pons, it's just below the pons, and it's anterior to the cerebellum. And this is really involuntary reflexes that is going on there. Things you can't necessarily control, including blood pressure, heart rate, and respiratory activity. You know, if you're that, you know, remember, you got a 4-year-old who wants that whatever inside the store, and they're going to hold their breath until they get their way. Well, the medulla oblongata is smarter than that. So, go ahead and pass out. You're not going to hold your breath until you die. We know better than that. What they probably didn't talk about during A&P was that it was made up of a couple of different types of neurons, some of which are dorsal, some of which are ventral, front and back. The dorsal respiratory group is primarily involved with innervating the inspiratory muscles. So there's some inspiratory cells that are present there. And they're going to go ahead and, when they trigger, when these cells emit electrical impulse, that goes down and triggers the diaphragm and the respiratory muscles to begin contraction and inspiration to start. They do have some input from other areas, the 9th and 10th cranial nerves, as we'll, if you remember back, those peripheral chemoreceptors, the ones that are in the aortic bodies and carotid bodies, they're going to go ahead and send impulses back that can also affect the triggering of a breath. And obviously there could be some stuff that is done from the cerebral cortex. You can voluntarily trigger that system faster or hold your breath. And not, it doesn't go on forever, obviously, but there is that ability. The ventral respiratory groups are primarily inspiratory and expiratory cells. So they're going to function not only during inspiration, but also during expiration. Just kind of looking back here, here's our medulla oblongata, the very base of the brain prior to the spinal cord beginning. And you can see it's just below the pons and just in front of the cerebellum. Just kind of giving you a little bit of anatomy. So we're looking at just basically these two, the dorsal and the ventral. Ventral along the sides, dorsals towards the center. And we said that the dorsal is primarily looking at inspiration, inspiratory neurons, the blue ones, while the ventral are a little bit of both. Now, the amazing thing is we really don't know how a lot of these things work. The way we know how they work to some extent is when there's damage to one of these areas, what ends up happening? Do we stop the triggering of a breath? Do we stop the beginning of an expiratory phase, meaning we have a prolonged inspiratory phase? But a lot of this is blind, which is kind of scary. There's one area that we really know very little, not very little, but we know less than we would like to know about how the brain actually triggers a breath on. So medulla oblongata is where it starts. That's the important concept that you have to have. There's two sets of groups of neurons that are present there, one that is ventral, one that is dorsal. Excuse me. Dorsal is primarily inspiratory, the ventral is primarily both. Then there's the pons. And the pons, the pons is basically superior to the medulla oblongata, it's right above it, and it has two centers also. One of which is given the name the apneustic center, one of which is given the name pneumotaxic center. So here's my medulla oblongata, and it's got those dorsal and ventral groups. Right above it is my pons with my apneustic center and my pneumotaxic center. These impulses come up and go to the apneustic center, and they're basically the inspiratory cutoff switch. So how does the brain know to tell the diaphragm to contract? That's in the medulla oblongata. How does the diaphragm know when to stop? That's from the apneustic center. It's going to be the inspiratory cutoff. It's going to be the one that says, okay, stop that impulse from going down to the diaphragm. We've had enough contraction. Seems like it's a simplistic method, but it's kind of the way it works. The pneumotaxic center is really kind of a fine-tuning of that impulse. That's probably the best way to think about it and all I'm ever going to say about it. Primarily what I want you to know, Pons has those two centers. Medulla oblongata has two groups of neurons also. So there's my Pons and my medulla oblongata. And that's these portion we're talking about up here. I have absolutely no idea what the nucleus parabrachialis medialis is, but it sounds really cool. I guess if I had a boat, I would probably name it that or something. So pneustic center, pneumotaxic center. That's the key part you need to know. One of the things that we end up having is damage to the medulla oblongata whenever you have a situation where you have a closed head injury. If you think about it, the cranium, the space in which the brain sits, is a fixed space. If you have swelling of that area, there is no place but for the brain to swell except downward. And what you end up having is a pushing down onto the medulla oblongata, compressing that, putting pressure on that, causing necrosis of that tissue and brain death. And when we talk about somebody being brain dead, we're talking about somebody who no longer has higher cortical functions, and they basically would only be able to be kept alive by use of a mechanical ventilator. Okay? Their heart, so long as there's oxygenated blood going to the sinus node, will continue to function. It doesn't need any external input. The diaphragm does. But if I have that patient who's a closed head injury who I intubate and put on a ventilator, they may still have a pulse and a blood pressure, but they're dead. They're brain dead because they have lost all that function above the medulla oblongata, which means that they're no longer a functioning human being at that point. They're a bundle of protoplasm lying on a table. You can also see damage to those processes through polio, not necessarily that causes brain death as far as higher cortical function, but you certainly can end up having the medulla oblongata not being able to send out those impulses. And certain drugs like morphine, all of your opiate derivatives, can end up depressing central nervous system function because it causes that medulla oblongata to be blunted. The impulses don't work quite like they should as far as sending out to the diaphragm to breathe. Okay? So it's kind of an important part of your body that we don't think about a lot, but without it functioning properly, control of ventilation, control of blood pressure, control of heart rate is severely impaired. Okay. So we talked about those peripheral chemoreceptors. I got a slide on that? Yeah. Previously, and I'll come back and talk about them in a half a second. But there are some chemoreceptors that are in the medulla oblongata, and these are responsive to hydrogen ions. What ends up happening is that the blood-brain barrier, remember there's a portion of your brain where there's a border, and that border is impermeable to hydrogen ions. So if this is the blood, I got a slide on this next, I probably should just go to it, and this is the brain, ions can't get across. They're blocked. But gases can easily get across. So carbon dioxide can get across. Those carbon dioxide going across, we remember back to the hydrolysis of water equation, ends up forming hydrogen ions. And it's these hydrogen ions that build up over here that cause you to take a breath. Okay. Let me give you a simple explanation of it here. First of all, there's my blood-brain barrier. Ions can't go across, but gases can. What causes the medulla to begin to cause said that but wrong. What causes the medulla to stimulate the diaphragm and begin a breath is a buildup of hydrogen ions within that area, within the cerebral spinal fluid. So Pam's sitting there and she's at end exhalation. What's happening during that expiratory phase is slowly but surely the level of carbon dioxide in her bloodstream is rising. Right? She's not ventilating, so there's a small, almost negligible increase, but there's an increase in carbon dioxide. As that carbon dioxide then comes through the blood-brain barrier, it's going to diffuse across. Because there's water inside the cerebral spinal fluid, it's going to go ahead and create hydrogen ions. Those hydrogen ions are then going to stimulate the medulla oblongata to go ahead and send out an impulse to the diaphragm to begin the next breath. So the reason why there's this rhythmicity to breathing is that there's a slow rise in CO2, slow rise in hydrogen ions inside the cerebral spinal fluid. That cerebral spinal fluid is bathing these chemoreceptors internally, and that's what causes then an impulse to come out of the medulla oblongata down to the diaphragm to begin a breath. CO2 levels then fall, and they gradually build back up again. So it's this waxing and waning in CO2 levels that causes a waxing and waning of hydrogen ions inside the cerebral spinal fluid, which then stimulates the chemoreceptors to take a breath. Holy Toledo, we never learned that in AP. Okay. This is why holding your breath won't work. Because you're going to raise the CO2 levels. Yep, voluntarily you can hold it for only so long before these hydrogen ions start saying, hey, stupid, take a breath. And actually you'll lose consciousness, but then you'll breathe. So Joey, no, you can't hold your breath until you get that toy. It's not going to work. We good on that? That's called the central chemoreceptors. Those are the ones that are present inside the medulla oblongata. Those are the ones that trigger the breath to happen. Very important concept. Central chemoreceptors. Then there's a peripheral, and we've talked about these previously. They're located in the carotid artery, the bifurcation of the internal and external carotid arteries. It's located in the aortic arch. Carotid bodies travel back to the glossopharyngeal nerve. The aortic bodies, the impulse travels back to the vagus nerve. And they're near those baroreceptors that look at pressure, but these are ones that respond to oxygen, CO2, and pH. And it's oxygen primarily that we look at. When your arterial value starts to get below 60, there's an impulse that is sent out to the brain to say, hey, we need to breathe faster. This is what causes tachypnea associated with hypoxemia. As you become hypoxemic, what's one of the things that ends up happening as a compensatory mechanism? You breathe faster. As you breathe faster, you actually blow off more CO2, and you end up with a respiratory alkalosis as an attempt to try and eliminate the hypoxemia. That function of this peripheral chemoreceptor, when you start getting really profoundly hypoxemic, it just kind of shuts off. It says, screw it, it ain't working. And becomes less of an effect on stimulating you to breathe. Central chemoreceptors inside the medulla oblongata, peripheral chemoreceptors, carotid and aortic bodies. And here's our carotid body you can end up seeing, and our aortic body inside there. And again, these are not only chemoreceptors that are there, there's also those baroreceptors we talked about when we talked about controlling of blood pressure, both located in the same area. So what ends up happening, I have a reduction in alveolar ventilation. We said a reduced alveolar ventilation will cause a reduction in alveolar values. Therefore, I'm going to have a reduction in arterial values. Carotid bodies, aortic bodies are going to be stimulated back to the medulla oblongata to increase ventilation and correct this problem. So it's this response the body makes to try and increase ventilation to alleviate the hypoxemia. Phew. Are we done yet? No. We need to talk about the reflexes. And these are a handful of reflexes that the body does automatically as a response to different things. First one is called the Herring-Breuer. Herring-Breuer. And a Herring-Breuer is a stretch reflex. The receptors located inside the larger airways and some of the medium-sized airways that when stretched, they trigger to shut off the tidal volume. So what prevents you from taking this massively huge breath? The Herring-Breuer reflexes. Okay, that's enough. You don't need to take any more. My bronchi have been stretched far enough. You don't need to stretch them any further. So they're basically there to shut off the tidal volume, a large tidal volume. During normal breathing, they don't kick in at all. That's where the inspiratory and expiratory centers within the medulla oblongata and the pons work. Second reflex is what's known as a deflation reflex, and this is what happens when you lose lung volume, especially rapidly. When you deflate, your body says, oh, we may need to breathe faster. So the response to this reduction is an increase in respiratory rate. Why it happens, we're not entirely sure, but it does. So there's an overinflation reflex, there's a deflation reflex. Don't need too much, but we don't want to be collapsed either. Third one, obvious one, irritant reflex. This is basically these receptors are located in the airway, especially the upper airway, and they end up releasing a vagal response to make us stop taking a breath. Some of this makes sense. They respond to mechanical stuff. I'm going to go ahead and stick the suction catheter in your nose. Oh, no, you're not. It's going to cause you to not want to take a breath in if I go like this. Okay? Or a bronchoscope, putting it in through the nasal. The body doesn't want that there. They don't want to breathe in, so they stop breathing. Same would be true with noxious gases. When they stimulate that area, you don't want to keep on taking a breath in. You want that breath to end. Don't keep breathing in that ammonia and bleach mixture. Stop. Same would be true with anything that would cause bronchospasm in the process. It's one of the premises as far as why asthmatics have bronchoconstriction is because they don't want that irritant to be entering into their system. Well, the same thing would happen here. You have an irritant reflex that prevents us from taking a deep breath in. They also stimulate things like coughs and sneeze and laryngospasm and gag reflex. These are all kind of the body saying, get this thing out of me. J receptors. Anybody ever hear of J receptors? Juxtapulmonary capillary receptors? These are cool ones. They're located in the interstitial space. And they sense when the pressure within that interstitial space rises. Why would it rise? Because I'm collecting fluid. Fluid's leaking out and building up pressure inside there, causing capillary congestion, edema of the alveolar walls, sometimes a PE, and the reflex basically stimulates a rapid, shallow breathing pattern. They start breathing like a spaniel. So somebody who ends up having, say, congestive heart failure, where blood backs up into the interstitial space, they end up having, as a response, them breathing rapid and shallow. They're called J receptors, J for juxtapulmonary, just next to the pulmonary capillaries. And you may or may not remember there's some juxtamedullary capillaries that are present within the kidney that have to do with the release of renin, converting into angiotensin 1, angiotensin 2, aldosterone.
Do we have to know it?
You will eventually. Not now, no. Oh,
You're just confusing.
I think she's just telling me to shut up.
In a nice way.
In a nice way. Okay, last reflex. And this is called the paradoxical reflex of head, or Head's paradoxical reflex. Head apparently was the guy who first defined this. And basically, it allows you to take a deeper breath than you normally would. For some reason, we periodically take a sigh. Why? To inflate alveoli that aren't necessarily inflated with each and every breath, we periodically just take this deep breath in. Also, what happens when what stimulates the first breath on an infant to begin crying. But that deep breath that occurs is something that you do physiologically need to be able to inflate all the alveoli at some point along the line so they're not permanently collapsed. Paradoxical reflex of head. Just sounds like a cool name.
Why are the receptors located?
Ooh, good question. I have no idea. I don't know. I'll have to look that one up. That's a good question. Where are they located? See if it shows it on here. I don't see anything on here. I don't know. All right. I don't know if I blew this up for you or not. I think it's inside your text, so you got it there. But this kind of puts it all together as far as all the different reflexes that you have. So we start off with our respiratory centers and the central chemoreceptors inside the medulla oblongata. That's what causes the impulse to start, so it goes to the diaphragm to begin contracting. The pons regulates that. The apneustic center, pneumataxic center regulates that impulse to tell it to stop breathing at some point along the line. We also have stretch receptors that are present and congestion receptors that are present, the J receptors, the irritant receptors, the stretch receptors that basically send impulses back to be able to say stop breathing. We have peripheral chemoreceptors, carotid body, aortic arch, that basically send impulses back via the 9th and 10th cranial nerves to be able to regulate breathing in the process. And then finally, we got to remember, there is voluntary control of ventilation that can exist also to cause things like emotional responses that can lead to hyperventilation secondary to just, I just broke up with my boyfriend. Okay. Pain can stimulate those. So there's all kind of other reasons why ventilatory patterns may be altered. Yeah. I think it's in Beachy. Yeah. Okay?